Hello, future nurses. This is Professor Flourish. Today, we're going to be talking about our neurological emergencies, part 1, head injuries. So like always, before we begin, I just want to talk about a little bit of our anatomy and physiology, which includes our ventricles and our intracranial pressure. So our ventricles are just 4 cavities that rest within the brain that produce and store cerebrospinal fluid. And if you remember, cerebrospinal fluid surrounds both your brain and spinal cord and basically acts as a cushion to protect from trauma. These are also responsible for removing waste and delivering nutrients to your brain. And like I said before, there's 4 of them. I like this picture here because it kind of very upfront just shows you exactly the functions of the brain ventricles. They're essential for central nervous system. They produce and store cerebrospinal fluid, which protects and cushions the brain and spinal cord from trauma. And the fluid also removes waste, delivers nutrients, and maintains temperatures for brain and spine. The next thing is a refresher of your intracranial pressure. I know we've kind of talked about intracranial pressure, but I kind of want an understanding of why we get so concerned about this increased intracranial pressure. So ICP is based off of this ratio of brain tissue, cerebrospinal fluid, and blood volume. So for a normal ICP, the range is usually about 10 to 15, with 80% of that being brain tissue, 10% being cerebrospinal fluid, and 10% being blood volume. Any changes that you have of any of these 3 elements can cause a change in your intracranial pressure. And an increase in volume of any of these components must be compensated for by a decrease in the volume of another. So for example, if we've got this big head, let's say we had a closed head injury, or even here on this picture, it depicts a bleeding ventricle, or even, so we've got this hemorrhage in our brain. Now, because of this hemorrhage, it's basically putting pressure on the brain itself, and it's pushing it to hit up against the skull here. So the problem with that is it can cause neurological damage. And also, like I said, if we have, instead of 10% of blood volume, we all of a sudden have 15%, then something else is kind of losing the amount of pressure it can have. So it just kind of puts in more than we have room for in the skull itself. And since the skull can't really expand, we're just sort of locked in to this area here. Some etiologies for possible increased intracranial pressure from our CVAs or our cerebrovascular accidents, our strokes, can be things like for an ischemic stroke, it's the swelling of the ischemic brain cells. For hemorrhagic stroke, it's that blood released into the brain cavity. So both those we'll kind of talk about more when we get into our stroke lecture. I just kind of want to put that in your brain while we're continuing on with this. Okay, so these are just some general reminders. I have both safety reminders as well as legal reminders. So the first one we're going to talk about is our legal reminder. So in emergency situations, when the patient is unconscious with no family presence, providers can override informed consent. So for example, if a patient comes in and it's a Jane Doe or a John Doe, no one knows who they are or what happened to them. They come through the emergency room. We don't want any delay in care. So this basically means we're going to rush them to the OR if that's what they need. We're going to make sure that we get them the care they need until we can figure out who their family are. We'd rather go ahead and do the surgery than possibly wait and have that delay in care. So that's more of your legal aspects. For falls, there are 2 different things you want to keep in mind anytime somebody falls. The first thing is to stabilize the neck, especially if you suspect that C1 through C7 could be compromised. You always want to stabilize it until X-ray rules out any fractures. So a lot of times what will happen at the hospital is when a patient falls out of a bed, the first thing we do is go ahead and put a neck brace on them. We do something to just make sure that they have that stabilized neck until it's time to send them to X-ray. The other thing is if somebody has sustained a back injury, you want them in a supine position and you don't want them to flex the spine. We kind of want it in that supine position without flexing. Finally, and I don't have this on here, but just as like a general care reminder, make sure that we are informing our families about everything that's going on, especially with some of these head traumas. When we get into them, it can be very frightening for the family. So a lot of times, one of the best things we can do is explain those equipments, explain things like vents, explain everything that we can that's within our scope of practice. And if you're not comfortable with explaining it, go ahead and seek somebody else out who is comfortable explaining it. Because the best way you can kind of get patients on board with what we're doing and their families on board is to let them know what's happening. So we are going to be talking about head injuries. So head injuries can be classified in two different ways. We've got open and we've got closed. Open means the integrity of the skull is compromised, and this can either be by a penetrating object or a blunt force. Either way, something has basically caused the laceration and there is an open wound. A closed head injury occurs from blunt trauma that causes acceleration of the head and then deacceleration or hits a stationary object. So for these closed head injuries, we don't actually see any lacerations. There's not any like blood or tissue damage on the outside, but there is damage to the brain on the inside. For these, they can be classified as mild, moderate, or severe, all depending on our Glasgow Coma Scale rating and the length the patient is unconscious. So that's why I kind of been pushing so much about understanding this Glasgow Coma Scale rating. You want to know what level of consciousness does my patient have? Are they able to verbalize with me? Are they able to move their muscles, like move their arms? Are they able to actually speak? It's a very quick assessment to see what their level of consciousness is. And it's something that you want to watch for. Did my GCS jump from a 15 to a 13? If it does something like that, or even like a 15 to an 11, if there's a sudden drop, that means I'm having a neurological change. That means something bad is happening. And this is just some more just general information. Your open-headed injuries pose a high risk for infections because once again, remember, with your open-headed injuries, you're not only dealing with the brain trauma, but you're also dealing with the trauma of the lacerations from the skin tissue. Scalp injuries often result in profuse bleeding. If you think about it, there's poor vasoconstriction of blood vessels on the scalp. So these are the ones that you're going to see that just bleed and bleed and bleed. Skull fractures can occur following forceful head injury. Brain may be damaged as a result. So patient may have a localized pain at the site of the fracture, swelling can occur, and nurse should be alerted for drainage from the ears or eyes, which may indicate cerebral spinal fluid. So what you're looking for is anytime you've got drainage that's coming from ears, eyes, nose, that's like a clear substance coming from them, I want to check for that cerebral spinal fluid. Sorry about that. So a cervical spine injury should always be suspected when a head injury occurs. So this is what I was saying, and it's important that you guys know this. So cervical spine injury must be ruled out prior to removing any devices used to stabilize the cervical spine. Neck stabilization is priority action. So like I said, anytime somebody falls, you want to make sure that their neck is stabilized. So the next thing we're going to talk about is our different types of head injuries. So on here, we've got concussions, contusions, diffuse axonal injury, and intracranial hemorrhage. So the first one is our concussion. So what a concussion is a jarring of the head, jarring of the brain within the skull. There may or may not be a loss of consciousness, and it occurs after head trauma that results in changes in patients' neurological function, but no identified brain damage. And it usually resolves within about 72 hours. So for these patients, a minor headache is expected. Now, you can have a post-concussion syndrome, which includes things like persistence of cognitive and physical manifestations for an unknown period of time. So like I said, you can have Okay. So the concussion here is, you can see where they're showing on this picture both a concussion and a contusion. So a concussion is that violent jarring or shaking that results in a disturbance of brain function. So here it's the actual action of it. Contusion is basically just a brain bruise, which we'll talk about in just a little bit. Now, with concussions, like I said before, a minor headache is expected. So the patient, that's not a need to call the primary care physician if they have a minor headache. That's just something that we expect to happen. Now, these are things that you need to call a primary care provider if the following were. So if your patient suddenly has projectile vomiting, they start vomiting a lot, they have difficulty speaking, difficulty awakening, facial drooping, severe headache, these are all reasons that you want to go ahead and call the primary care physician. So when you think about it, if they're vomiting profusely, that's kind of alerting that there's something wrong with their brain, because our vomiting center is located in our brain. And if we vomit a lot, our body is just kind of telling us there's a problem with it. Difficulty speaking and difficulty awakening can both be level of conscious changes. Facial drooping, they may have developed a stroke. Severe headache means that there's something going wrong. Maybe they all of a sudden had something worse happen. Minor headache's okay, severe headache is not okay. So contusions, this occurs when the brain is bruised. So on here, on this autopsy, you can see these little contusions. Patient will have a period of unconsciousness, which is associated with stupor or confusion. And this may occur along with other neurological injuries, such as with subdural or extradural collections of blood. So your diffuse axonal injury is basically a form of traumatic brain injury. It happens when the brain rapidly shifts inside the skull as an injury is occurring. The long connecting fibers in the brain called axons are sheared as the brain rapidly accelerates and deaccelerates inside the hard bone of the skull. They typically cause injury in many parts of the brain, and people who suffer from this are usually left in a coma. So it's seen in a very severe head trauma, and it usually typically follows blows to the unsupported head in motor vehicle accidents. So as you can see here, it's an issue with the axonal or the axons actually being damaged. And you can kind of see it here too, where we've got the Melian sheath, the axon stretching, or that shearing force. So the next one is our intracranial hemorrhage, and this can occur in the following areas. You can have epidural, subdural, intercerebral space, subarachnoid hemorrhage, and all these are different types of hemorrhages. So your epidural, and this is basically just a collection of blood following a head trauma. And there can be a delay of weeks to months in manifestations for a subacute or chronic subdural hematoma. So with these, we can develop hematomas in these different areas. So for example, if you've got an epidermal hematoma, it basically forms rapidly and results from arterial bleeding. Hematoma forms between the dura and skull from a tear in the meningeal artery, and is often associated with loss of consciousness, followed by lucid period, and then rapidly progresses to a coma. And an epidermal hematoma is a surgical emergency. It's usually the most serious type of hematoma. Subdural hematoma forms slowly and results from a venous bleed. So epidermal hematoma is usually artery, subdural is your venous. And this one occurs under the dura as the result of tears in the veins crossing the subdural space. Intercerebral hemorrhage occurs when a blood vessel within the brain ruptures, allowing blood to leak inside the brain, and subarachnoid hemorrhage is bleeding into the subarachnoid space. It may occur as a result of head trauma or spontaneously, as from a ruptured cerebral aneurysm. So your epidural, so your epidural and subdural are both your hematomas, while your intercerebral and subarachnoid are both your hemorrhages. Okay, so the next thing we're going to talk about is our prevention and risk factors. So for our preventions, you want to wear helmets, seat belts, and everything else. You want to avoid dangerous activities. You want to lock up your firearms, avoid riding in the back of pickup trucks, and promote elderly safety, as older adults who sustain head injuries are at a greater risk for complications. Some of your risk factors are things like motor vehicle or motorcycle crashes, illicit drug and alcohol use, sport injuries, assault, gunshot wounds, and falls, which always count as a trauma in our older adults. So our assessments. So what I've done here is basically split up our assessments between ones that you'll do in the emergency setting. So let's say that you're just driving home from work. These are the kind of assessments that you want to do very quickly, to the assessments that we're looking for when our patient is admitted to the hospital. So for the first assessment, we are talking about just general things we're going to look for. So things we're going to look for with our patients are things like amnesia, so that loss of memory before or after the injury, loss of consciousness. So when we're doing that quick assessment, we want to know the length of time and whether or not the patient is unconscious, because the length of time the patient is unconscious is significant. You're looking for CSF leakage from the nose and ears, which can indicate the basilar skull fracture. You're also looking for peripheral response to pain. So with this, you can do the nail bed pressure, which checks both basic motor and sensory of patient. So with this, it's on this next one. Basically what you do is you get a pen and you put pressure on it to see if the patient's going to react or not. Because just think about it, if you were to put a pen on yours, you're going to kind of flinch backwards and you want to see if they're going to pull back or what's happening with that pressure. So these are the assessments for your basilar skull fracture. So what you're looking for is any of that bleeding from the nose and ears, oturia, rhinuria, and you're looking for CSF. And CSF is usually positive for glucose. And the other two signs that you're looking for are your battle sign and your raccoon eyes. And we're going to talk more about your CSF, what that looks like in a little bit, but I kind of want to focus on this battle sign and raccoon sign. So the battle sign, and I've got a picture here, is basically this little bruise that is right under your ear. Oops. And you can see it in an actual patient here. That's the battle sign here. So what you're looking for is that post tallicular ecchymosis on the mastoid bone. So basically you're just looking for a bruise that's right behind your ear. The raccoon eyes are periorbital ecchymosis around the eyes. So if they're bilateral, their presence suggests that there's a basilar skull fracture. And this appears from the rupture of meninges, causing the venous sinuses to bleed into the arachnoid villi and cranial sinuses, resulting in that pooling around the eyes. And basically, if you see battle sign or raccoon eyes, this requires immediate action. So that's why I kind of say that these are the ones that your emergency assessments. So if you see your patients with either of these, you're getting concerned that they may have had that basilar skull fracture. So as you can see here, they actually look like a raccoon. Now, if a patient were to come in and they're wearing something like glasses and you can't really assess it, the first thing you want them to do is just take off sunglasses, take off glasses, so you can actually assess them for the raccoon eyes. And look, on here, you can see it a little bit better, where it really does have this like raccoon eyes here. Like I got this picture mostly so you guys can see battle sign and raccoon sign. The next one is just assessing for CSF leakage. So what happens is if a patient just got bonked on the head really, really hard, you're going to be looking for that raccoon sign, the basilar sign, and also you're going to look for any fluid that's coming out of their nares or ears or even eyes that is a clear liquid. So the thing you want to do is basically test for the halo sign. So the halo sign, what that is a clear or yellow tinted ring surrounding a drop of blood when bloody drainage is placed on a piece of gauze. So this is kind of a very easy, quick assessment to do. And I put up a lot of pictures on here so you can kind of see what it looks like. And what's going to happen is they're going to form these concentrated rings. So it's going to look like these little rings, and it's going to test positive for glucose. So you want to watch for the CSF leakage whenever there is a basilar skull fracture and the patient is having clear liquid coming from nose or ears. So anytime they have that, if you were to just walk out into the middle of nowhere and somebody gets that basilar head injury, you want to look for that battle sign, raccoon eyes, and then check their CSF fluid leakage. And with that, you can do the gauze check, which is a very quick check, and then you would alert wherever they're going, and they can do an actual test to see if it tests positive for glucose. And it makes sense that it's going to test positive for glucose because CSF is filled with glucose. So these are other manifestations of increased intracranial pressure in the emergency situation. So with this, if you have increased intracranial pressure, and remember, if they had that basilar head injury, that means that suddenly now we're having more blood pooling in there, which is very toxic to the brain, and we're not having enough space for our brain tissue. So they're going to have things like a severe headache and vomiting. So those are some of the things that you'll see right away with that increased intracranial pressure. They're going to have deteriorating level of consciousness, restlessness, irritability, and look at your pupils. They can be unequal, dilated, pinpoint, non-reactive. So your pupils are like your best friends when you're trying to check these neural assessments. You want to see what's happening, because if it's unequal, that means that I might have increased intracranial pressure. Ulcerations and breathing pattern. They might have that breathing pattern that's basically like the and then apnea, then so you want to assess how they're breathing. Deteriorations in motor skills, abnormal posturing. So if they've got flaccidity, decerebrate or decorticate. So if they're either making like the E's with their hands or they're making the C's, you want to look for that. Signs of seizures. And then finally, your Cushing's triad, which is a late sign. And with your Cushing's triad, you're going to have things like severe hypertension, widening pulse pressure, and bradycardia. So here I've got this lovely little picture that kind of helps you with your Cushing's triad. And these are the three primary signs that often indicate an increase in intracranial pressure. So their systolic pressure is going to go up, but their pulse goes down, respirations go down. Okay, so now we're getting into our assessments of after the patient is hospitalized. So these are the things we look for once our patient is in the hospital. So after the patient has been admitted, you can monitor their ICP by placing a screw, catheter, or sensor through a burr hole into the ventricle, subarachnoid, epidural, or subdermal space. And if you just want a refresher, you can see the assessment lecture for reference on what each of these are. Your expected reference range is usually 10 to 15. So these are things that can increase your ICP. Hypercapnia, which is basically just an increase in your carbon dioxide in the bloodstream, which can lead to cerebral vasodilation. ET tube or oral tracheal suctioning can also increase intracranial pressure. So you do want to be careful when you're suctioning out your patients. Coughing can increase it because anything that's putting pressure up through here. Extreme neck or hip flexion or extension. Maintaining the head of bed at an angle of less than 30 degrees and increasing inter-abdominal pressure. So restricted closing, basal maneuver, anything of that nature can increase it. So another thing that happens with our head traumas that can potentially increase the cerebral oxygen demand is our hyperthermia. Elevated temperatures can be caused by damage in the hypothalamus, regulating center. So manifestations are things like increased temperature, shivering, hypoxia. So with this, you want to assess your neurological status and vital signs. You can give them a hypothermal blanket or cool sponge. You want to monitor their ECG. You can give them a fan. You want to initiate the seizure precautions and prevent shivering, because that shivering can increase your ICP. So that's why we talk about hyperthermia when it comes to our brain injuries, because like I said, if it causes a damage to the hypothalamus, then they can't really regulate their temperature appropriately. And when that happens, they have more cerebral oxygen demand, they're having shivers, we're concerned about that intracranial pressure. So now that we talked about ways to increase it, these are ways that can decrease your ICP. So these are things that you want to do to kind of help your patient. So you want to elevate head at least 30 degrees to reduce ICP and to promote venous drainage. Avoid extreme flexion, extension, or rotation of the head, and maintain the body in midline neutral position. And that's very important after a certain type of craniotomy that we'll talk about. But like I said, what you want to do for most of your, whenever you're dealing with trying to decrease your ICP, you want that elevated head at 30 degrees, and you want the body to maintain that midline. You want to maintain a patent airway, provide mechanical ventilation as indicated, patient receive a stool softener, and avoid like bearing down or that basal maneuver, which can increase ICP. You want to provide a calm, restful environment, limited visitors, minimize noise. So you kind of want to make sure that you're not having too much noise. And remember, your patients, even if they're vented, they can still hear you. So just kind of making sure the family knows that hearing is typically the last thing that they lose. So just letting them know that, hey, be mindful of what you're saying. So hyperventilation is avoided during the first 24 hours because it can cause cerebral vasoconstriction, which leads to ischemia. However, hyperventilation for intubated patient can be used after first 24 hours following injury to help lower ICP. So if they're in that first 24 hours, no hyperventilation, but after that 24 hours, you might see them using hyperventilation in hopes to help lower it. So these are your continuously monitoring things. So these are the things that you're going to constantly be looking at. You want to monitor the patient at a regular scheduled intervals for the following. Respiratory status. So your respiratory status is your priority assessment. So since the brain is dependent upon oxygen to maintain function and has little reserve available if oxygen is deprived. So untreated hypoxia leads to brain injury or death if the brain has been denied adequate oxygenation for 3 to 5 minutes. So changes in level of consciousness can occur, and that GCS provides the earliest indication of neurological deterioration. So your priority assessment for this is always your respiratory status. Even if your patient's vented, you still want to go in and make sure that they're breathing okay. It's not just the respiratory therapist's responsibility to look at that. So your respiratory rate and monitoring that respiratory rate is very important. The other things that are important are things like your cranial nerve function. Do they have eye blink response, gag reflex, tongue movement, and shoulder movement? Are they able to do these things? As you can tell, I do care that you know these cranial nerves, because I want you to know if something, all of a sudden they had a cranial nerve function and then it disappears, that can alert you that something's not right. You want to assess your pupils. Remember, unequal pupils indicates increased intracranial pressure. So pupils should be round, equal, reactive to light, and accommodation. Bilateral sensory and motor responses. Are the grips the same? Is weakness noted unilaterally? So looking to see, am I getting the same pressure on both hands? So these are just some of your lab test and diagnostic procedures. So lab test, obviously respiratory is a big thing. So we're going to look for our ABGs. Our complete blood count's important, blood glucose levels, because remember, the brain is that little prima donna that loves having its sugar. So making sure that my glucose levels are fine. My electrolytes, monitoring anti-seizure medication blood levels. Are they getting enough of their seizure medication? Diagnostic tests can be cervical spine films to diagnose cervical spine injury, your CT, your MRIs, and your ICP monitoring. The next thing we've got is our treatment. So these are our medications, our therapeutic procedures, nursing care, and our interprofessionalism. So our medications. So the different medications we have are mannitol, barbiturates, phenotone, and our opioids. So mannitol. So mannitol is an osmotic diuretic, which is used to treat cerebral edema. When it's used for increased intracranial pressure, it draws fluid from the brain into the blood. And what's going to happen is you're going to see your patient pee a lot. So for these patients, you usually insert an indwelling urinary catheter and you monitor fluid and renal status. So what will happen with it is your patient will order this mannitol and you'll go ahead and you'll make sure, because these are the things that you want to do, is for mannitol, you want to make sure you have a pump because you're going to be giving it IV. You want to make sure that your tubing has a filter because mannitol crystallizes. So one of the things that you'll kind of see with it are they're these really big crystals. And if you have a chance, I'll probably show it in class what it looks like, but if you have a chance, look up crystallized mannitol and you can see why it's so important to have that filter. The other thing you want is to go ahead and insert that urinary catheter, because what can happen is they are just going to immediately pee. Everybody I've given mannitol with, basically just as soon as it goes to their vein, they are ready to go. So with it, you want to monitor for hyponatremia, hypovolemia, and polyuria, because once again, because we're giving them this osmotic diuretic, so I basically say it's like this super diuretic, I'm going to have to look out for things that are shown with hypovolemia. So that's things like my hyponatremia, my hypovolemia, and then just a whole bunch of urine. The other thing is your barbiturates. So patients can be placed in a comatose state in order to decrease cellular metabolic demand until ICP can be decreased. Medications that are usually used are your pentobarbital and your thiazopental. Neurological assessment is a lot more difficult when the patient is placed in this barbiturate coma. Medication dosage will be adjusted, and usually what they'll have is a mechanical vent, cardiac and hemodynamic monitoring, and ICP monitoring are all required. Now with this, it really depends on your neurologist, your neuro doctor, because some of them will go ahead and put them in that comatose state. It's kind of like the difference between if it's a neuro case or a trauma, because a lot of the traumas, they will go ahead and put them in that comatose state for a couple of days, let the brain rest. Once the ICP is down, then they'll take it off of them. But if they think that it was something that there's neurological damage and the patient's not coming back, they'll start weaning them off and off and off so we can see what they're doing neurologically. Phenotone, like I told you guys, this is one of those drugs that you just gotta know. So it's used prophylactically to prevent or treat seizures. It's a first-line medication to suppress seizures that did not depress the entire CNS. Dosing for this medication is patient-specific and based on therapeutic blood levels. So as the nurse, you want to make sure that the patient takes the medication at the same time every day, and you're watching for that gum health for your patients. Opioids are things like your morphine, sulfate, or fentanyl. Honestly, for a lot of your head injuries, we really do avoid opioid use as much as we can. Even with our mechanically vented patients, because of the CNS depressant effects, a lot of times the fentanyl will be like their last thing that they'll put up. They'll put them on propofol, they'll put them on all kinds of medications before they'll put them on an opioid, just because of that CNS depressant. We want to see everything the patient can do. So because it makes it harder for us to assess their true neurological system, and because it can cause that respiratory depression, it's pretty much usually avoided. Now, that doesn't mean that we don't use it. It's just they'll try to avoid it. Or if they have it, they'll lower them until it's a very, very low amount. So you want to administer things like Narcan or naloxone, the versatile agent, if patient becomes over-medicated or does not tolerate the opioids. So pretty much anytime somebody orders opioids, they also order Narcan because they want to be able to have that option where we can reverse the opioid effect. So these are your therapeutic procedures. So we're going to talk about our craniotomy first. So this is just general information about a craniotomy. It's basically the removal of non-viable brain tissue that allows for the expansion and or removal of epidural or subdural hematomas. It can also be used to decrease ICP and remove brain tumors. And it can include drilling a burr hole or creating a bone flap to permit access to the affected area. So your craniotomy can be kind of different things. You can have it where it's going to remove part of the brain tissue. You can have it be as simple as I'm going to drill a hole or remove part of the skull in order to kind of release that. Because if you remember what we said, the brain can only have so much pressure in here. We've got 80% brain tissue, 10 CSF, 10 blood. So if suddenly I've got more in here, my brain has nowhere to go. So to kind of alleviate some of that, they'll go ahead and drill a hole or they'll remove part of the skull. Something that's interesting about this, and this is more just a fun fact, is that these craniotomies were even done like way, way back in the day. Like honestly, in ancient Rome, they used to do the same thing. They would drill burr holes in patients to release spirits. Only now we know why we do it. We do it because it releases pressure. So it's kind of interesting to see that little tidbit of history when it comes to some of the procedures we do. It is a life-saving procedure, but it's also associated with many potential complications. So honestly, we try to avoid doing this unless we absolutely have to, because first of all, it can cause severe neurological impairment, infection. So craniotomies are filled with infection. They can cause, you can end up causing meningitis. You can end up causing different kinds of problems from craniotomies. So you just want to watch for infections, and it can cause seizures, neurological deficiencies, or death. So honestly, we only do it if it's something where it's like nothing else is working. We have to do this now. So intracranial hemorrhages requires surgical evacuation. So there's three types of surgical approaches. You've got superior entroial, which is above the tentral, the intra-entral, which is below the tentral brainstem, or transsphenoidal, which is through the mouth and nasal sinuses. Burr holes are basically just those circular openings through the skull, and it's used to assess cerebral swelling, injury size, and positions of the ventricles. So these are your nursing actions after a craniotomy. So we've got different types of positioning, which anytime you're trying to lower ICP, you are going to maintain the head of bed at least 45 to 45 degrees with head and neck midline to prevent increased intracranial pressures. So for your superior enteral surgeries, so that would be ones that come up this way, then you're going to kind of go with that same head of bed at 30 degrees, head and neck midline. The only one that's different is that interferential craniotomies, which is basically means that it's below that tantrum. So that means that it's back here near the cerebellum. Now for that one, you're going to keep the patient flat and on either side for 24 to 48 hours to prevent pressure on the neck incision site. So they're just basically going to be laying side to side. So once again, with your craniotomies, your ABCs are priority, and it's always that airway. So no matter which craniotomy you have, you're going to be looking for that airway. So they have different medications you're going to give with your craniotomies. Your mannitol is for cerebral edema. Dexamethasone is to reduce cerebral edema. Phenatone is to prevent seizure activity. Ondansetron is to prevent nausea and vomiting. Because if you look at this, I would not be surprised. Pretty much what we would get whenever our patients had a craniotomy is it was a given that you're going to have dexamethasone pretty much on all of them. So it's a steroid, and we're just trying to reduce that cerebral edema. The other one you would have is, unless it was counterindicated, that phenatone, and then just a PRN of ondansetron. And that's because, once again, vomiting and nausea can put increased pressure. You want to look for, monitor your ICPs, as well as monitoring your cranial nerve function. So just making sure that if they've had that surgical evacuation of a hematoma, that you want to look for things like your oxygenation, looking for your ICP. You want to keep the patient calm, reassure patients, explain equipment post-op to the family and patients, monitor patients for signs and symptoms of meningitis. So just kind of looking for those things. Does my patient have a stiff neck? Does my patient, are they positive for Kernig's sign? Are they positive for Brzezinski's sign? Looking for that. And like I said, priority is always your airway. Okay. So this is just some general nursing care for your head injuries. So things like maintaining that cervical spine stability until they've been cleared by x-ray, reporting the presence of CSF leakage to the provider. So if all of a sudden you see that they've got clear substances coming out of their nose, you do the gauze check and you see that they've got these little circles on it, these little rings, letting the provider know. Implementing measures to prevent complications of immobility, so turning every 2 hours, footboard, splints, anything of that nature. Maintaining safety and seizure precautions, so making sure that we've got padded bed rails, making sure that we know if our patients are at risk for seizures. And also remembering that hearing is the last sense affected by a head injury. So making sure that you're explaining everything to the patient and informing the family that the patient can still hear. So I always treated it, no matter what level of comatose my patient had, unless they were like pronounced brain dead, I would still talk to them as if they were GCS 15. I would still explain everything to them. I would still go through all the motions with them. And the reason for that is because I knew that hearing was their last sense. So these are just some more general reminders. You just want to make sure that you're watching for your ABCs. You want to watch for any neurological changes, decreasing Glasgow Coma Scale, decreasing level of consciousness, cranial nerves, means something is going wrong. So like I said, GCS is a very quick indication of, my patient went from 15 and now they're at a 13. My patient went from 13 and now they're at a 9. Something is not going right. Once again, patients will lose hearing last, so be mindful of what is said in the patient's room and just explaining everything to the family and patients on an ongoing basis. So for your interprofessional care, care should also involve other disciplines such as physical, occupational, recreational, and/or speech therapists. You want to contact social services to provide links to social services. Rehabilitation facilities can often be utilized. So now let's go ahead and talk about some complications. So these are things like brain hernia, hematomas and intracranial hemorrhages, and pulmonary edema. So brain herniation is the downward shift of the brain tissue due to cerebral edema. So what happens is the brain is swelling so much that now it's swelling downwards. So this is what I was talking about the other day in our class about why it's important to know about a cerebellum stroke, is because you don't want that brain to start herniating down and causing any issues on the brainstem. So the brain consists of brain tissue, cerebrospinal fluid, and blood. Due to the limited space within the skull, ulcerations of any of these of the brain can result in compromise to the others. When trauma creates a shift in these components and the other components are unable to accommodate, the brain herniates. Brain tissue moving downward through the foramen magnum. So with it, the findings you're going to find are things like fixed dilated pupils, deterioration of level of consciousness, the Chern-Stokes respirations, hemodynamic instability, and abnormal posturing. Usually recovery is rare, and urgent medical treatment like mannitol and or surgical treatment such as debulking is indicated. So even with treatment, severe neurological impairment usually persists. So if the brain actually starts herniating, that's when we know that this patient, we're most likely going to have a different conversation with the family. So for this, most of it is prevention is key. These are the things where you want to make sure you're watching your patient. Make sure that you are closely monitoring your vital signs and neurological status. Early reporting of GCS changes. So like I said, I know I keep talking about your GCS, but if you see your GCS change, that is a huge indicator that something's not going right. You want to frequently update your family and look for and report changes in the patient. So sometimes your family members can be the best indication of what's going on. So the next thing is your hematoma and intracranial hemorrhage. You want to monitor for severe headache, rapid decline in level of consciousness, worsening neurological function and herniation, and changes in your ICP. Surgery is required to remove subdural and epidural hematomas, and intracranial hemorrhage is treated with osmotic diuretics. Next thing is pulmonary edema. Finding usually mimics acute pulmonary edema without cardiac involvement. It is a life-threatening emergency, and once again, immediate aggressive treatment is used, and unfortunately, survival is rare. So the other thing that can happen with it are things like diabetes insipidus, or syndrome of inappropriate antidiuretic hormone. So you just want to make sure you're monitoring your blood electrolytes and osmolarity, document strict intake and output, weigh the patient daily, treat electrolyte and fluid balances as prescribed, and monitor for dehydration or fluid overload during treatment. So brain death. This is supporting and understanding brain death. So with brain death, and I want you all to be very, how do I put it? I want you to understand the difference between brain death and a comatose patient, because true brain death meets a certain criteria. You have to get this criteria to actually be considered brain death. I've got an article on Momentum that goes over the criteria in more detail, but basically it consists of 3 parts. You've got a physical examination, an apnea test, and an acellular test. So your physical examination is basically the, they'll check all the cranial nerves and see if they're working. They're looking for things like posturing. They're looking for any sort of things that would indicate that the patient is only using reflexes and they're not actually consciously picking anything. An apnea test, and I've got 2 videos that we're going to watch in class that goes through the physical examination as well as the apnea test. And both those just kind of show what we're looking for in each of those tests. The ancillary tests are basically things like cerebral angiograms, things to see if there's anything that's indicating that there's some sort of viable activity in the brain. So like I said, if somebody's truly brain dead, then there's certain things that have to be met for it. So I like to definitely let my patients know, and if I don't know how to explain it, I definitely get a provider to talk to them about it, because it's very important that they understand if their patient is brain dead. If they're brain dead, the patient is basically, no, they are dead. So brain dead equals dead. It just basically means that there's no electrical activity whatsoever. To be in a comatose state, that means that there's still activity happening. So it's just important to know the difference between the two. And with that, when the patient's actually brain dead, what you want to do is your role at that point is supporting the patient's decision, and basically if they want to accept or decline organ donations. So at that point, it's mostly just family support and talking to the family about what it is their family member wanted. Like I said, both these videos here, and you can see them on Momentum, they both go over, so this first one is the actual brain death evaluation, and he goes through showing a demonstration of everything they're looking for. The next one is your actual apnea test. So it shows what they're looking for on the vent. And like I said, if you're really interested in it, I do have that article that's up there that you can go through, because I think it's important that we use appropriate terminology when it comes to our patient care. You don't want to refer to a patient as brain dead unless they're truly brain dead. As always, thank you, and let me know if you have any questions.